So the last speaker is Professor Stuart Jones. He's chair in pharmaceutical medicine and heads a research team at King's College in UK. He's interested in how therapeutics agents are released from formulations and how they cross biological barriers. So his talk today is topical therapeutic gases.
Okay, thank you for that kind introduction, and nice to meet you all. It's my first time to this SPIM conference, and I'm really enjoying all the talks. So thank you to the organizers for inviting me. It's nice to be back in France, and hopefully I'll bring forward what we hope is an emerging concept in terms of using gases to treat topical infections. So there should be some follow-on from the last talk, hopefully. So just to introduce myself, I'm a pharmacist also, but I run a lab of about 14 researchers, and my chair is not in dermatology, but in pharmaceutical medicine, because I'm interested in taking molecules and devices from concepts into products. So that covers the whole of the medicines development spectrum. I've got different themes in my laboratory. So we're interested in skin barrier function. We've got a non-invasive device to extract ISF from the skin. I'm interested in infections, in vitamin D, and photoaging, and also in the microbiome. I'm currently the president of PharmaTrain, and this is a European organization, some of you might know, that regulates or tries to bring quality standards into medicines development across Europe and the world. And I really enjoy traveling, so thanks for allowing me to come to France, which is great. And if you haven't heard of the conference, the Gordon Research Conference, the Skin Barrier Function Conference, which will occur in August 2025, I'm the next chair in 2027, so hopefully we'll see some of you there at that conference. It's very topical, I think, for this meeting. So I'm going to follow on from the last talk. I'm going to talk a little bit about topical anti-infectives. We'll talk about some mechanisms of anti-infective resistance, and then bring in emerging concepts. And I'll note that phage treatment is an emerging concept. And then I'll focus on therapeutic gases and give 3 case studies, one about soft tissue infections, one about onychomycosis, and one about wound healing. So we're going to move a little bit away from the skin into the nail, but I hope you forgive me for that. Okay, so just as we heard in the last talk, in terms of therapeutic agents, so I'm talking translationally, if we want to treat an infection, if a GP, a general practitioner, wants to treat an infection in its early stages, it's quite difficult. Why? Because the products that we use, there's quite a few products to treat superficial infections of the skin, the nail, and the hair. And the antimicrobials and there's antifungals. The antimicrobials here we can see are in purple and the antifungals in green. A lot of them are quite effective. So if we put them in the laboratory and we measure the minimum inhibitory concentration, you get a really good result. But when you use them in the body, they tend not to work so well. And one of the reasons for this is the inaccessibility of the infections. We often think that skin and cutaneous infections are sitting on top of the skin and we can treat them and kill them quite easily, but that's not always the case. So one of the major problems for local conditions is accessing those organisms, and not just a few of the organisms, all of the organisms, to make a complete kill of those organisms in the skin, the nail, and the hair. So often clinicians, they turn to oral therapy or systemic therapy quickly because they don't believe these therapies work. And they've seen many times when they haven't worked, and therefore we're causing or fueling this antimicrobial resistance problem even from these superficial infections of the skin, which is probably not right. They start off quite simple infections and we should be able to treat them. So this is quite important, and there's this concept of recalcitrant infections, and what do I mean by this? So we tend to think that infections are short-lived. The pharmaceutical industry won't fund antibiotics why? The main reason is money, of course, but it's because they believe that infections, you treat them after a few weeks, then they've gone. It's not a chronic condition, and therefore we don't spend much money on antibiotics, so we can't make much money. We can make a lot more money from cancer. But actually, this is not the case. There's lots of people, there's probably people in this room that have an infection right now, and it's a recalcitrant infection. What do I mean by this? Well, for example, a hair follicle infection. Many of us get a hair follicle that's blocked and infected in our body, and it stays like that for many, many years, untreated, because why? It's incredibly difficult to treat infections once they're in the hair follicles or in the appendages. Likewise, onychomycosis, the statistics would say at least 10 people today in this room have got an infection in their toenail. And most of us don't do anything about it. We leave it for the rest of our lives and we will die with it. And this is a recalcitrant infection. And this is an issue because recalcitrant infections, having these pathogenic organisms around our body, can lead to other infections, and it can lead to worsening of our microbiome and also can lead to resistance. So there's some papers that have been published that have now started to show that these long-term infections facilitate resistance that occur in the skin, and then that can worsen. And what happens is these recalcitrant infections, we might treat them or half treat them with the topical antibiotics or with the antifungal agents, and then those organisms start to generate resistance, and then this resistance organism can become invasive, and this will cause the systemic problems. So now there's a move to try and remove these recalcitrant infections, for people to treat these what are quite simple infections and to remove them from the body, because this might be fueling this antimicrobial resistance. And this is, of course, Antimicrobial Resistance Awareness Week, so it's quite important to think about that. So what's the solution? If we've got antimicrobial resistance and we've got these skin infections, these nail infections, these hair infections, which seem to be quite minor, what can we do? Well, we probably shouldn't use those traditional antimicrobial, antifungal agents, because we want to reserve them. We want to reserve them for those people who are seriously ill that need these as life-saving therapies. So now there's a move to try and think of alternatives, and this is where we talk about the emerging concepts. We've heard about phages, which is one option. There's also something called lysine therapy, which is not the traditional antimicrobial agent which we can use. We've heard, all of us, I'm sure, about antimicrobial peptides, which are obviously not traditional antimicrobials. Nanoparticles, nanomaterials themselves can be antifungal and antimicrobial, so this is interesting. Metallic ions have been around for a long time. They have different mechanisms of actions of the normal organisms and normal compounds. And then we've got this idea of gases, and this is what I'm going to focus on today. So can we use gases as a topical therapy for these topical bacterial infections and fungal infections? So I was quite taken aback by one part of the world, which is New Zealand. So I'm a pharmacist, and this came out of the pharmacist area. So sometimes there's a little bit of a tension, some clinicians in the room, between pharmacists and clinicians, because pharmacists often stop clinicians doing certain things. We tell them they can't prescribe X, we can't prescribe Y, they're spending too much money on X. So this here is something you typically see from a pharmacist. It says, topical antibiotics for skin infections, should they be prescribed at all? And in New Zealand, what they were doing was saying, because these agents aren't really working, they're adding to antimicrobial resistance, let's just get rid of them and let's use antiseptics. So in the graph on the right-hand side, there was a big campaign, public campaign, to try and stop doctors from prescribing mupirocin and fusidic acid, to reduce those and prescribe hydrogen peroxide and povidone iodine, which is an topical antiseptic, to work on these superficial infections. And you know what? It worked. It had some positive outcomes in terms of treating infection, and also reduced the amount of antibiotics being used. So this was seen to be a positive thing. And there's some studies, there's a clinical trial in progress at the moment in New Zealand, which is looking at these types of antiseptics for impetigo. So I thought this was interesting. So what's the difference between an antibiotic and an antiseptic anyway? You know, this is an important question. So they both kill fungi and bacteria. Well, the antiseptic generally has a broader mechanism of action. It works used not through a specific mechanism, but through multiple mechanisms or through ubiquitous mechanisms. And they tend to work on the surface of the skin. So that's perhaps their limitation. So could we get something that worked like an antiseptic, that there was low resistance potential to, and it could be used for these superficial infections? And what I'm going to try and convince you of, the graph didn't come up. I'm going to try and convince you that gases can be used as this topical antiseptic. Why? So gases are interesting molecules. The most interesting for me, thinking about the skin barrier, is that they're very small. So what we learn at university is we've heard a lot about biology today, but one of the most important things about treatment in the skin is getting the molecule to the place where it needs to go in the skin. So all of these molecules that we think are interesting, we tell the chemists the first thing you must do is go and speak to a pharmacist and check that the molecule will get into the skin. It can be formulated. Because on paper, we know which molecules will get into the skin and we know which molecules won't get into the skin. So it's the same in terms of discovery biology. We need to think about this. So in terms of gases, these have got the perfect properties to get into the skin because they're very small. So the molecular weight is about 30. The skin has a molecular weight cutoff of around 300 for easy delivery, and if we change the skin, we can increase this. So it means that nitrous oxide and hydrogen sulfide, which are probably two really interesting molecules because they're biologically important, they can get into the skin theoretically very quickly. The graph that you can't see, what it shows is that nitric oxide can penetrate the skin and it can also penetrate the nail. So it penetrates both tissues, being small. Interestingly, what we found was hydrogen sulfide can penetrate the nail, but it can't penetrate the skin. And lots of people think the nail is the same as the skin. It's completely not. The nail is made up of protein, and the skin has got an outer layer of lipid. So these two barriers are completely different. We do have to think about them both when we're developing products for the nail because you get cross-contamination. But this was an interesting finding. And those two molecules, they're interesting because they're both effective against bacteria, viruses, and fungi. So this gives you the idea that there's an antiseptic action, that they're effective against a wide range of species. So let's try and use these molecules. What can we do with them? Here's one case study. This is thinking about soft tissue infection. So one thing about soft tissue infection, following on from what I said earlier on, infection, the clinicians, when they see infection, it's usually terrible. You know, it's a very severe case. But out in the community, you can get lots of mild infections. But even those mild infections, they can be in different locations in the skin. And to get the antiseptic or the antibacterial or whatever you're using, it's got to reach that location in the skin. And that location may be in the deep skin, it may be in the superficial skin, and we've got some examples here. If we don't reach that location, then the antibacterial, the antiseptic cannot work. So what we need to do is try and select a molecule that can reach that location of the skin. So what we thought was, in terms of soft tissue infection, nitric oxide can penetrate the skin. It's got an antimicrobial, antifungal, and antiviral action. So could this be used to treat soft tissue infection, and perhaps it can avoid this drug resistance problem because we can get a lot of the molecule there, we can kill all of the bacteria, and there's no real resistance mechanism to nitrous oxide because it's got a free radical type of killing mechanism. So instead of starting with the biology or the microbiology, in this case we started with the delivery. Okay, we can be, as a pharmacist, we normally start with this. I do it both way around. Sometimes I start with the clinical trial before the molecular biology. Sometimes we do the molecular biology first. Here we saw in the skin, this is human skin in a Franzell laboratory. On the left-hand side, you can see that nitric oxide can get into the stratum corneum, but it passes through into the epidermis, and on the right-hand side, it actually passes into the dermis. This is not too surprising if you're a clinician, because nitrous oxide, using these GNSO donors, originally were used for cardiovascular disease. So there is an idea that nitric oxide can be applied to the skin and it can pass through the skin. So we formulated that into a solution and into a patch, and we've shown that this nitric oxide can get into the skin. But with infections and tissue infections in the skin, like I said earlier, there's two areas. We saw some really nice molecular biology this morning, and we saw how different areas of the skin express proteins in different ways. Well, of course, it's really important that we get these molecules into those different areas, and then are they effective in those areas? So testing nitric oxide against bacteria and fungi, unfortunately, is not very potent. So we've got these two elements of the coin. It's got to be potent and it's got to be deliverable. So here we can get nitric oxide into the skin, but on the left-hand side we can look at the viability, and GNSO on the bottom, it takes milligrams of GNSO to kill the bacteria. That's not good. It's difficult to get milligrams of agents into the skin. On the right-hand side, it takes milligrams of GNSO, the nitrous oxide donor, to kill the fungi, and that's not good. So maybe nitrous oxide could be useful, but it needs to be a little more potent. Let's move on to the next case study. So hydrogen sulfide is much more potent than nitrous oxide. And for both these molecules, how do we deliver it? We take a chemical, and that chemical will release the gas. So it breaks down and it releases the gas into the tissue. This seems quite attractive. For anyone in the room who's got a fungal infection of the nail, it's really difficult to treat. You don't really want to take oral terbinafine because you have to have the liver function tests and it's got potential for side effects. You have to take it for a decent amount of time, months, and then it takes a year for the infection to clear up. So most people ignore it. Some people use topical therapies. In the UK, we only have one available. I think in France you have more than one, and in the rest of Europe. These are applied to the nail plate, and it passes through the nail and it treats the infection from the outside in. However, if we do an experiment to monitor how quickly something passes through the nail, it takes around 2 weeks for the agent to pass into the nail, and then only a tiny amount of that agent passes into the nail. My PhD supervisor once had a talk at a conference, as hard as nails. And he was saying that the nail is the most difficult barrier in the whole body to pass, and it certainly is. It takes weeks to get past. So some people use devices, they use photodynamic therapy, and they use lasers. All of these show some activity, but generally about 1 in 3 patients get cured when they're using this treatment, and that's not ideal. When you're paying for it, you're going through the difficulties. So these therapies for nail infection aren't great. So what we did at King's is we devised a new system. I think I was influenced by my PhD students. I was definitely. One of which, who was using the nail bar quite a lot. I thought about this concept of using an artificial nail to fill hydrogen sulfide into the back and then apply it to the nail using an acrylic adhesive. This is important because if we deliver a gas, then the gas will of course disappear into the atmosphere. So one idea is to try and keep the gas contained so it will get past the environment. And what happens with this is that the hydrogen sulfide is loaded into the back. It's got a cover like a transdermal patch. The patient takes the back of the cover off, and then we apply it to the nail. The hydrogen sulfide goes through the nail plate, but hydrogen sulfide doesn't go through the skin. So it's the perfect cosmetic product because hydrogen sulfide doesn't pass through the skin. I gave this presentation to another conference, and straight away I had quite a few cosmetic companies asking me about acne and various other conditions, because a compound which only treats the superficial area of the skin is really interesting as a cosmetic. So does this work? When we tested the penetration of the hydrogen sulfide through the nail, remember I told you it takes about 2 weeks for most molecules to get through the nail. In 4 hours, everything that we had loaded onto the top pretty much passed into the nail. This was a really surprising result. In fact, we had to do the experiment several times, or the student did, because the supervisor, myself, didn't believe this was what's happening. Maybe there's a leak in the cell that we were using, maybe something had gone wrong, but they repeated it. Sodium hydrogen sulfide, which is the donor, and ATTM, which is a hydrogen sulfide donor. In 4 hours, we got almost complete penetration in the nail and saturation in that tissue. And you can see cyclopirox, which is a commercial competitor, it was on the baseline, it didn't even pass through the nail. And we get about 500 to 1,000-fold increase in terms of flux. And our hypothesis was it was just simply to do with size. So in terms of the nail, size matters. So the smaller molecule, the hydrogen sulfide, was so small, it was passing through the porous pathway in the nail and being able to get into the tissue. And just to prove that, what we did did a literature survey. This is published in Drug Discovery today. And we looked at every single nail penetration study, and we ranked them based upon molecular weight. And you can see here there's a correlation between molecular weight and log permeation. And the higher the log permeation here on this graph up the y-axis means faster permeation. So the smaller molecules get through the nail plate much faster. And when we plotted our data for hydrogen sulfide onto the graph, we saw it fitted to the line. So almost definitely the penetration ability of hydrogen sulfide through the nail is because of its molecular weight. It's very small. And then to prove that we needed the cover, does the gas evaporate? Could we just apply a gel to the surface of the nail? We did a permeation experiment with an open chamber where the chamber was open to the environment. The gas evaporated, of course, into the environment and then didn't penetrate through the nail. When we had a closed chamber, we've got a cover on it, we get penetration through the nail. So that proves the concept. Oh no, is it going to have the same problems as nitrous oxide? Is it going to be potent? Well, there's a lot of data here, but on the left-hand side, it's quite simple. This is the gas. So remember, we've got a gas and we've got a liquid. We apply a liquid and then we've got the gas. One turns into the other. So we need to test the potency of both the liquid and the gas. On the left-hand side, it's the gas, and it's 100 nanogram per mil sensitive. So this is 10,000 times better than the nitrous oxide. This is against T. rubrum at the top, and at the bottom against C. albicans, and it's about 14 microgram per mil sensitive, so it's a really strong result. On the right-hand side, we take some human nails and we infect them with C. albicans. You can see the small balls in the middle, and we do a kill assay, and we can see that the hydrogen sulfide is a little bit worse than cyclopirox, but better than amolafin. These are marketed products. And on the right-hand side, you can see T. rubrum, the long stringy hyphae you can see of T. rubrum, and the hydrogen sulfide here is as good as cyclopirox and better than amolafin. So sodium hydrogen sulfide, generating hydrogen sulfide, is really potent. Then with our collaborators in the University of Bath, they checked the spectrum of action against loads of different bacteria and different strains of fungi, and they showed it worked through everything. So it's got this antiseptic mechanism of action, and it can work even against antibiotic-resistant strains. Why does it do this? It's because it's this general mechanism of action, and it's a general transport mechanism. So the hydrogen sulfide passes through the cell wall, the cell membrane of the organism through passive transport. It doesn't need a transporter. That's one mechanism of resistance that's thrown out of the window. And then once inside, it causes massive cellular damage using this free radical mechanism of action. And on A and B, you can see the hyphae from T. rubrum. We've used their redox probe. On the left-hand side is the no treatment, the A, and you can see it's blue. On the right-hand side, green. This is the redox reactions occurring inside the hyphae of T. rubrum. So we think this is the mechanism of action. This is some data that's come out of the lab from last week, so right off the press. To get this to market, so I'm a translational scientist, I go all the way to clinical trial, and I run the clinical trials myself. We need animal toxicology. Here's the animal toxicology. The first thing the regulator will ask is, what kind of product do you have? And I want to convince them, for regulatory purposes, I've got a medical device. So to have a medical device, we don't want any systemic absorption. So it's like it's a cosmetic, but it's used for medical indication, so it'll be a medical device here. And so we did a rat study. A rat's an interesting model to choose for nail infection. Usually we use guinea pigs, but you can't do pharmacokinetics with guinea pigs. So we used a rat model and we adapted the cover. On the left-hand side, you can see the cover. And then the next graph, you can see the deposition in the nail. So you can see after a few hours, again, the nail's completely full with hydrogen sulfide. And in the middle, you can see the plasma concentration of sulfur doesn't change at all. There's no systemic absorption. We'll use this for the regulator. And then the other question that the clinicians came back with, so we work with clinicians directly from the start of the project, and one thing that they said was, doesn't hydrogen sulfide smell? Isn't there a sulfur smell coming from the hydrogen sulfide? If you use IMAC or the hair removal creams, they smell a little bit sulfury because those compounds are sulfur-based. It's the same here. And so what we're doing right now is we're doing a panel test with participants to check if they can smell the hydrogen sulfide when they use the product in vivo. And we've got 3 doses. It's blinded at the moment, but this is all the participants that we've had so far. There's about 40 participants. And you can see even the 3 doses, the smell is at least or the worst, moderate, and we think our products, you won't be able to smell the smell at all. If there is a smell, I know, France, we'll be able to solve it with your perfumeries, so it should be okay. So the last case study, so hydrogen sulfide is very effective, but there's some questions still. What happens if someone is still really impatient to get their infection treated? Or will this hydrogen sulfide work with really complicated infections like in wounds? In wounds, actually, you've got a very limited time to have an intervention, because when the wound gets debraded, the wound gets opened, we want to remove all the antifungal, the bacteria and the fungi, so we can get wound healing. So we want a treatment that's going to work really quickly. So what we did was, we went to the conference in Bath and we heard about plasma. I've never heard about this plasma. It's a state of matter. And they were using helium plasma and they're using argon plasma for wound healing. And this facilitates, through 3 radicals, wound healing, and also it's got an antimicrobial effect. So of course, we thought, can we use hydrogen sulfide as a plasma treatment? Could it make it even more potent? What is plasma? It's a gas which we apply a current to, we make it charged, and it generates free radicals. Those free radicals make the molecule even more potent than it was before. And hydrogen sulfide can actually help with wound healing in terms of angiogenesis and anti-inflammatory. So we saw these physics papers that showed that H2S could be made as a plasma, so we thought, okay, let's give it a go. So we've got 1 postdoc and 1 PhD student in the lab looking at this plasma. So what does plasma look like? It's quite cool to work with. This is the plasma jet coming out of, this is electricity applied to a mixture of argon and hydrogen sulfide. It makes a jet, and these are free radicals, charged radicals, coming out at the end of the plasma. So we've done some preliminary experiments, and I'll show you again, first time I've shown these experiments. We took the plasma jet and we did a typical MIC experiment with bacteria. So we applied the plasma jet to the bacteria inside some growth medium, and in 5 seconds we killed everything. So this was really interesting for wound healing. This is a 5-second treatment of hydrogen sulfide mixed with argon. Preliminary data. On the left side, we can see T. rubrum and C. albicans fungi, and we use 14 seconds here, a treatment of plasma, fungi a little bit more resistant, and this is a kill assay, and we can see a significant reduction in T. rubrum and C. albicans from this plasma treatment. So we're talking about a few seconds of this plasma treatment being applied to a wound. It could completely remove the organisms from the wound, and it could be useful for wound healing. Imagine this is an initial intervention before the wound healing process is really initiated. So hopefully I've talked about an innovative way to use gases, a new kind of therapeutic intervention. We think this has got broad application. We're thinking about using it in acne. Anything that's affecting the hair follicles, we think hydrogen sulfide could be really useful for. It's a signaling molecule used in biology, so how does it affect those signaling processes could be interesting. In psoriasis and in lots of inflammatory conditions, hydrogen sulfide signaling is dysregulated, so we're interested in this as well, working with a pharmacologist. It's got a broad antimicrobial, antifungal, and antiviral spectrum of action, so how can we use it? Definitely it's got potential in onychomycosis. We're taking this into now a medical device and trying to get the UKCA marking and then go into clinical trials. This is the grants that we have at the moment. And we've just started 2 projects looking at hydrogen sulfide for wound healing. And we've got a few companies that are interested in using hydrogen sulfide for acne. We've done some tests on resistance. I got asked at a previous conference, what about resistance? Have you checked this? We've done some reculturing of the organisms by treating them at subtherapeutic levels over and over and over again. We can't see any resistance from hydrogen sulfide at the moment. This is some initial tests, but we want to look at that in a little bit more. So just say thank you to the collaborators. So we worked, I'm not a microbiologist myself, Albert Bahelius from the University of Bath, he's the expert mycologist and microbiologist. We've got Mohammed Al-Hanan next to him, who is the 3D printer who makes all the nail devices. And then in the middle, Fritz, who worked at the University of Bath, he's a microbiologist. And then the guy with not much hair is Osama. He's the one who invented the nail device. Maz and Ali in the graduation gear, and then Sarah Nesrat-Din and Ali Al-Tabai, who are students who are working on the plasma device. Thank you for your attention. I'm happy to answer questions.
You hear me? Yeah. Thank you very much for this nice presentation. Any questions? Yes, please. And then.
Thank you very much for the nice presentation. I think smaller molecule than this would be hard to find for treatment. What I wonder is if you treat wounds. I mean, you said that the hydrogen sulfide doesn't penetrate the skin, but in the wound, you do not have the skin barrier, so doesn't it get into the cells, and couldn't it have some unwanted effects? So that's the first question. And the second, why doesn't it penetrate the skin if it's so small?
Yeah, good questions. In the wounds, you're correct. So I didn't have much time to talk about the wound healing part. I focused on the other bits. But we've done more traditional cytotoxicity assays, and we're using it at the, a non-cytotoxic effect. Of course, hydrogen sulfide is a gaso transmitter, so it's in the body. So there is a window of activity where it's safe, and it's very potent. So we've got quite a lot of room, actually. But you're right, it would be entering the body and in the systemic circulation and wound healing. And in fact, that's a benefit. So in the body, it actually facilitates the process of wound healing by modulating the inflammatory process. So I'm working with a collaborator, Alex Dyson, who's a pharmacologist, and he's looking into the mechanism of action of how actually this works. The second question, why doesn't it get into the skin? Really interesting, and I'm wondering about other gases, whether I've investigated hydrogen sulfide most. So interestingly, hydrogen sulfide is a gas as H2S, but when you use a donor, and normally we're using gels or something to apply, it's in the liquid state. So it needs to pass through the liquid state to become a H2S. During that time, it actually ionizes and becomes HS-. So the species that we're actually applying to the skin is HS-, and that doesn't penetrate the tissue. The H2S could theoretically penetrate the tissue, but it's off in the air, and the contact is low. It does have a lower density than oxygen, actually, but we find there's not much contact with the skin. So in short, the answer is it's because when we're in the liquid, and the liquids we apply, it stays as HS-. It's a negatively charged compound. It really doesn't like the skin, but it likes hair follicles and appendages.
Okay, thank you very much.
Other question? No, so if no other question, thank you very much.
Thank you.
So this session is finished, it's closed.